The following podcast is part of a certified educational activity. Access the entire activity and complete the post test at peerview.com/EME860. Downloadable slides and practice aids are also available.
Hi, I'm Dr. Elizabeth Teal, Director of the Herscott Center for Tuberous Sclerosis Complex at the Massachusetts General Hospital in Boston, and I'd like to welcome you today to Applying Evidence to Practice, updated consensus recommendations for the diagnosis, surveillance, and management of tuberous sclerosis complex. And I'd like to introduce you to my colleague, Dr. Ilana Paul, who will join me today in the discussion, and she's Director of Kidney Care at the Herscott Center for Tuberous Sclerosis Complex at the Massachusetts General Hospital. So first, Module 1, we're going to discuss diagnosing TSC, the importance of early detection, and would like to start with a video of the parent journey discussing the diagnosis of their child with TSC.
And I'm here to tell you about my oldest son, Elijah. When Elijah was born in 2007, when he was just 7 months old, we traveled to California to introduce him to his great-grandpa. During that trip, Elijah was irritable and had great trouble sleeping. Every time he tried to fall asleep, he seemed to startle himself awake several times in a row with sharp movements of his arms and cries in between. A call to our pediatrician reassured us that he just needed a sleep routine, but we were alarmed when on the plane ride home, he startled several times, looked off to the side for several minutes, and fell into a deep sleep for 2 straight hours. We videotaped the next startle episode to show to a neurologist. She examined the video closely and told us that it was an infantile spasm, the most catastrophic type of seizure. She offered us words intended to be encouraging that instead were devastating. She said, "Some children with infantile spasms even go to kindergarten." We were in shock. Until that moment, we'd thought Elijah was developing normally. He was admitted immediately to the hospital for testing. An MRI revealed that his brain was riddled with tubers, too many to count, and that he had a small subepidermal nodule, classic brain manifestations of tuberous sclerosis complex. The neurologist told us that while the diagnosis of TSC was not good news, at least now we knew the cause of his spasms and could begin to treat them with vigabatrin, which is especially effective for TSC patients. At the time, the only means of getting vigabatrin for us was through a pharmacy in Canada. We were told that prescription packages were often held up in customs for several days, and we couldn't imagine needing to wait to start treatment. In the 8 days from when we noticed Elijah's first infantile spasm, his spasms had doubled in length and become more frequent. He would be snuggling on the couch at home or strapped into a stroller at the grocery store when all of a sudden the characteristic pattern of a spasm would begin, and we would start counting the rhythmic thrusts of his arms, filled with the anxiety of knowing that the longer he continued to have spasms, the more likely he was to have developmental disabilities and autism later. And we were tortured by the notion that perhaps these subtle seizures had been going on for months without our notice, but with potentially devastating consequences for his future. Before our eyes, he became much less alert. He couldn't make eye contact. His primary mode of speech was groaning. His muscle tone grew flabby. He cried and couldn't fall asleep for naps despite hours of bouncing and being walked around the neighborhood.
With that story in mind, I'd like to remind all of you that tuberous sclerosis complex, although it is rare, is not really rare. And we know it affects about 1 in 6,000 births, meaning about 50,000 individuals in the United States have tuberous sclerosis complex, and 2 children born each day in TSC have TSC in the United States. If you look worldwide, it's really almost chilling that a baby born every 22 minutes in the world has tuberous sclerosis complex. What we also know about tuberous sclerosis is that it's a very complicated disorder affecting multiple organ systems throughout the body, actually infecting almost every single organ system. And we know that TSC is associated with a very wide range of symptoms, and the severity, there's a spectrum. Some people are very mildly affected, others are very severely affected, even within families. To diagnose an individual with TSC, over the past 10-15 years, we now have genetic abilities with the TSC1 and TSC2 gene testing, and a person can be diagnosed with tuberous sclerosis based on a gene identification. We also continue to use clinical diagnostic criteria, And as we'll see in the next slide, these involve major criteria, and an individual can be diagnosed with TSC by having 2 major criteria or 1 major and 2 or more minor features. We also believe it's important to diagnose a person with TS if they have possible TSC, because the different manifestations of tuberous sclerosis can occur at different times through an individual's life. So if we feel an individual has possible TSC, that person also needs to be followed closely to see if they do develop other symptoms. And this slide shows the diagnostic criteria and the current updates from the 2012 consensus conference to the updated 2021. And as you can see, they're mainly the same, with the exception of now for the brain. The criteria is multiple cortical tubers and or radial migration lines. And for the minor criteria, sclerotic bone lesions, which are seen very commonly in children and adults with TSC and are not clinically significant, but are identified on x-rays. What we do know is very important is it's to diagnose TSC in an individual as soon as possible. Many times babies are diagnosed, or the presumptive diagnosis is made due to detection of cardiac rhabdomyomas prenatal on ultrasound. In fact, it's thought that 35% of fetuses with TSC do have cardiac rhabdomyomas that could possibly be detected on ultrasound and then confirmed following birth with echocardiogram. We also know if there's a family history or a suspicion of TSC, prenatal MRI can identify cortical tubers and subependymal nodules. And we believe the early diagnosis then would allow for immediate referral to a specialist in TSC, typically a neurologist, as well as education of the family about the condition and how to identify seizures, and also allow early intervention, since many individuals with TSC do have developmental impairments. This is a slide that just kind of shows with time when the different symptoms of TSC develop in childhood. And what we do know is the 2 most common things leading to the diagnosis in infancy are both the cardiac rhabdomyomas as well as the hypopigmented skin macules and also the onset of seizures. The neurologic features of TSC, the brain is involved in about 90% of individuals with tuberous sclerosis. We know seizures are very common, occurring in at least 80% of individuals, often occurring with onset in less than 1 year of age. We also know that infantile spasms are very common in babies with tuberous sclerosis, occurring in up to 40% of cases. Intellectual disabilities affect about 50% of individuals with TS and are often severe. However, it's also very important to note that 50% of individuals with TSC have normal cognition. Autism is also very common in TS, affecting 30 to 50% of cases. And importantly, over the past many years, increasing awareness of TAND, TSC-associated neuropsychiatric disorders, has really become a feature of TSC education and care. These are very common, affecting almost every individual with tuberous sclerosis complex, and can include ADHD, obsessive compulsive disorder, aggression, sleep disturbances, learning disabilities, depression, anxiety, bipolar disorders, etc. And what we know in the TS community is these are often undiagnosed and untreated. Many years ago, the TAN checklist was developed in order to help clinicians facilitate trying to identify if individuals are experiencing any of these, so they can be recognized and treatment can be implemented. And Alana, kind of going from the brain to the other organ involvement, can you kind of share with us about kidney, etc.?
So absolutely, happy to. The kidney involvement in tuberous sclerosis is a very common feature that generally presents a little bit later than some of the neurologic features that are present at time of diagnosis if an infant is going to be presenting with seizures, for example. The kidney involvement can be detected when a child already known to have TS is screened for kidney involvement, and sometimes it's detected incidentally when someone doesn't have tuberous sclerosis and they are imaged for whatever reason, and the lesions are found in the kidney. And those lesions can be tumors, and most of the tumors of TS are benign tumors. They're angiomyolipomas, and they're found in huge majority of patients with tuberous sclerosis, at some level or another. They can have very few, very small lesions, or they can have very large ones that are a significant burden for the patient's health and significant consequences on the morbidity and mortality in the long life, not necessarily in the children. And there are also cysts in the kidneys, which are simply the fluid-filled pockets that themselves are not tumors, and do have similarities to other cystic kidney diseases, except in tuberous sclerosis, in a pure TS situation, the cysts themselves rarely cause problems physiologically, although there is a small subset of patients who have tuberous sclerosis who also do happen to have polycystic kidney disease, which is a progressive disease that affects the kidneys with growing cysts and long-term problems with kidney function. And I just want to emphasize that's a small subset of patients with TS who have cysts. Then closely related, believe it or not, to the tumors, to the angiomyolipomas of the kidneys, there are tumor growths in the lungs. These cell types are called lymphangioliomyomatosis, and we abbreviate it LAM for short because that's much easier to say. And LAM is something that young women are screened for. It doesn't present in childhood at all. This is often seen in women in their 20s and 30s, although as soon as they hit puberty, we start discussing when to get baseline studies. And the risk of having LAM increases with age and increases and changes with the hormonal cycles of women, and we can discuss that later. The other common finding that is not as dangerous for someone's general health, but can have a huge impact on their mental health and self-image and sense of self, are the facial angiofibromas, which are again cousins of the AMLs, very similar tissue types across the board. These are small little fibrous tumors that occur on the faces of folks with TS, particularly on the nose and on the cheeks, and they can be mistaken for acne in a teenager, and they develop and grow over time and become very prominent in later adolescence. And in some cases, folks handle them okay and they can get used to them. In other cases, like I said, they can be disfiguring and very upsetting. And in some cases, they actually are problematic because folks who don't have the ability to self-regulate and can pick at their skin and pick at these lesions, it can cause serious bleeding issues and problems.
Thank you, Ilana. So I think that what we know, since tuberous sclerosis complex can and sometimes does involve multiple organ systems, what we have found is really multidisciplinary care is really helpful in taking care of both children and adults with tuberous sclerosis complex. And Ilana and I are both involved with the Herscott Center at the Mass General, which provides care to both children and adults. And Ilana, kind of, how do you feel that our program or programs like ours, how do you feel that helps the patient journey with TSC, both in diagnosis and kind of in following patients?
Well, I think there's sort of the universal thing that helps when one patient sees multiple subspecialists. It's so much easier if they're within a single center, within a single electronic medical record. This, of course, is with the current computer systems, we can stretch across different institutions, and that's helpful, but it's nice to have people being able to come and see their multiple specialists over the course of one day or a couple of days. If they're coming from out of town, they can do one-stop shopping and see neurology and nephrology and gastroenterology if they need to. They can see psychiatry if they need to. They can get their imaging studies done. I think that's really very convenient for the families. And I think that they are so reassured that we actually discuss each case with each other, that no one is working in a single silo in a specialty without conferring with the other specialty. So it's really sort of, it gives us the ability to give more holistic care for the child and the family and to address the different needs that they have.
No, I agree. I also think what I've learned doing this now several years, it really also increases the institutional awareness of TSC. I've had patients tell me that our sedation nurses in radiology seem to know more about TS than any physician they've seen before. I also think it helps us understand TSC better. I think kind of knowing, and we get together and we talk about the different organ involvement, and it allows us to really understand the overall TS better and what does brain involvement can help tell us and inform us about pulmonary. I also think it helps improve the patient journey with regard to safety. As we're going to see kind of in further discussion, some of the treatments that are being used for some symptoms of TSC can have significant drug interactions with medications used to treat other symptoms. And I think without that communication, that dialogue, that awareness, that could create more complications for some patients. So I think that most of us would agree, and I think the patient community would agree, that if possible, multidisciplinary care is really optimal. Realistically, that's not always possible. And so I think that a lot of patients I've talked to over the years can have anxiety that they don't have access to one of these multidisciplinary programs. And that's where I think the value of the TS Alliance and the patient advocacy groups becomes so important. And what I tell patients in that situation is you need a doctor. You need a doctor who's willing to learn and to work with other people and to work with these teams. And what we've seen, I think, during the COVID pandemic, one positive has been the expansion of telemedicine to where we've really been able to see patients, TS patients in other parts of the country and the world, and work with their physicians to really optimize their care. So, Elon, go ahead.
I think the other thing about the multidisciplinary approach, which is often challenging, is that there's a real separation between pediatric specialists and adult specialists. And one of the things that we have in our program, which is nice, that you and I specifically will sort of cross that age barrier, and we can see both children and adults, and then some of the additional specialists we find who are age appropriate in our group. And then I really do enjoy working with the local doctors or the local physicians who, for patients who cannot travel or for whom it's inconvenient, I'm perfectly happy to talk to another nephrologist 100 miles away and say, sure, that's a great idea, or maybe you want to think about this. And I find it very rewarding for the care of the patient and also as a colleague in collegial interactions.
No, I completely agree. Like we also often call ourselves a happy family. So thank you for that. And I think now we'll move on to Module 2, which will cover TSC screening and monitoring from infancy through adulthood, with 2021 updates to the International TSC Surveillance Recommendations. And we'd also like to start this with a patient story with a mother of twins with TSC describing her daughter's journey.
Hello, my name is April Cooper, and I have identical twin daughters with TSC. It's been 17 years since I first heard the words tuberous sclerosis complex. Back then, the only obvious issue was seizures and getting them controlled for my daughter Amelia, who was only 2 months old. In the early years, our lives were consumed with medical appointments, testing and monitoring, multiple therapies, testing and more monitoring all times too. We were dealing with medical issues with one group of professionals and observing developmental issues with another. Having identical twins, we could watch in real time the damage that TSC was creating for Amelia, because without seizures, Abby fell within the normal range of development, while Amelia slipped further and further behind. On the spectrum of TSC seizures, clinically, Amelia's seizures didn't seem so bad. However, the damage being done subclinically was horrendous. With half a brain full of tuber mass, the surgical team at UCLA did not hold much hope that we would find the focus of her seizures. But she was deteriorating before our eyes, and something had to be done. Fortunately, one lucky seizure was captured during a MEG scan and located the focus. And soon after her second birthday, Amelia had a successful brain surgery to stop her debilitating seizures. While Amelia has not had a seizure in over 15 years, her development was obliterated by those early seizures. She did not sleep through the night until she was 4. She wasn't potty trained until she was 7, and her only word was hi until she was 8 years old. Once the medical issues subsided, her behavior became front and center. Amelia spent most of her waking hours frustrated, moaning to communicate, crying unconsolably, hitting herself in the head, and making everyone around her miserable. We soon realized that Amelia's window of opportunity to learn was closing, and we needed to push her harder. Learning is torture for Amelia, and the process causes her great stress and pressure. Abigail is a great example of just how variable this disease can be. Early on, Abby had a couple febrile seizures but never developed a seizure pattern and was therefore never put on anti-seizure medication. It appeared as though she was going to be spared. We felt so lucky. Little did we know that being spared was close to impossible when you have TSC. When Abby was 6, she developed a SEGA tumor growing deep inside her brain, which had to be immediately removed. While on the surface, Abby appears typical. She's been under the constant care and supervision of a psychologist since she was 6 years old, battling both anxiety and depression. At 14, Abby went through a serious bout of depression, which caused her to start cutting herself. Learning and fitting in with her peers is a challenge for Abby, and she works very hard at both. Through it all and against all odds, Abby just finished her junior year of high school with close to a 3.0 GPA. The girls will be an adult in less than 3 months, and I'm very afraid. It may sound strange, but I'm actually more concerned about Abby's future than I am about Amelia's. Amelia's issues are easy to see, and it's obvious that she will need 24/7 care and supervision for the rest of her life. But Abby has dreams of being married and starting her own family someday. We wonder, when we're no longer around to care and support and guide her, will she be crippled by her constant depression and anxiety, or will her lack of confidence lead her astray? Her issues are subtle, and I'm afraid that her inherent naivety can easily be taken advantage of by someone who is selfish and unconcerned. Medically, we know both girls have angiofibromas on their face, kidney angiolipomas, and SEGA tumors, which remain stable due to their medication. But will that change? Will either or both start having seizures again? And because they are female and their chances of developing LAM is upwards of 40%, will they be spared, or will this just be added to the long list of challenges that await? No one knows what the future holds for these two, and while we feel that Abby and Amelia have been pretty lucky with this disease, we know the odds are not in their favor. Thank you.
So then what we'll go through now are the recommended evaluations for newly diagnosed or suspected TSC with updates in 2021. And they're listed here, and just to point out that what we have appreciated is, in addition to infantile spasms, which we have often, or we always, kind of try to educate families about the importance of recognizing those and treating those, is that many infants will also have focal seizures, sometimes that have maybe gone unrecognized previously because they can be very subtle. So increasing awareness of focal seizures, and then again TAND. And I think you'll see kind of repeated through this presentation the incredible importance of TAND and the importance of not only recognizing that it exists, but coming up with a systematic way for evaluating TAND, both at diagnosis, when a person first comes in. I've diagnosed people in their 40s, and when you talk to them about TAND and anxiety, they realize that it's something that they've really struggled with much of their life. Again, often never diagnosed and never treated. So a big and very appropriate emphasis on the importance of screening, recognizing, diagnosing, and treating TAND. And then, Ilana, I'll turn over to you for the other recommendation changes.
Yeah, okay. So for the diagnosis, there aren't that many changes outside of the neurologic area. The kidney diagnoses, the pulmonary diagnoses, and other features are more or less the same. In addition, for the ophthalmologic, it used to be only the fundoscopy for the hamartomas, but now they're also adding in the achromic patch. And I think for details about these diagnostic criteria, there is a practice aid that can be downloaded along with this program.
Thank you for mentioning that, because this is a pretty data-heavy presentation. So there are practice aids that have been developed both for the clinical diagnostic criteria, surveillance, as well as treatments, and also one focused on TAND. So we would encourage you to download those for the complete information. So thank you, Ilana, for reminding me about that. So in addition to diagnostic recommendations, the consensus conference has always discussed surveillance and how do we follow people with TSC to make sure that we optimize their health. And so this slide kind of shows you what the recommendations are with regard to the genetics, as well as the central nervous system. And the big change here has been the recognition that since seizures are so common onset in infancy, as we said, over 70% of children with TSC have seizure onset in infancy, and since we are having emergent evidence that early treatment can have profound impact on outcomes, now the recommendation is to not only obtain an EEG at time of diagnosis, but if the diagnosis occurs in infancy, to obtain a routine EEG in asymptomatic infants, so those are infants without any evidence of clinical seizure activity, every 6 weeks up to the age of 12 months, and then every 3 months up to the age of 24 months, as data has shown that abnormal EEG findings frequently precede the onset of clinical seizures. Again, identifying that and allowing early treatment, because we and others have shown that the sooner and more effectively the seizures are treated, the better the outcomes with regard to cognition, autism, behavior, etc. And then again, TAN, the recommendations are that not only think about this at time of diagnosis, but this is something that needs to be assessed at every visit. Again, using the TAN checklist or other methods to try and identify if individuals are having significant anxieties, OCD, ADHD, which can profoundly impact their ability to function. So really important, TAN, and I think this is a very reasonable focus on TAN, because especially as children, adolescents, and adults, for many people, TAN becomes the most significant morbidity of having TSC. And then Ilana, I'll turn over renal back to you.
So the surveillance recommendations for the kidneys, again, have not changed very much, but I do want to take this opportunity to emphasize that we do serial imaging of the kidneys to look for development and progression of the renal lesions. And it's really important to have high quality imaging, and MRI is the standard of care. Not all patients can have MRI because sometimes they have hardware, vagal nerve stimulators, for example, cannot be subjected to the MRI magnet. And for those patients, we recommend getting CT scans. And we recommend getting either MRI or CT on average every 1 to 3 years, but it does vary case by case depending what the renal tumor burden is and the age of the patient. And I think it's important to bring that point out for everyone. These are certainly guidelines, but each patient has their own story and their own history, and the guidelines need to be adapted appropriately. Of course, with renal monitoring, in addition to the imaging, you want physical exam, particularly blood pressure screening for hypertension, and you need some labs. You need to know what their urine looks like, and you need to know what their creatinine is, so you know how their kidney function is, and you can follow rates of change as they age.
And Ilana, would you like to address the pulmonary recommendations for surveillance?
So as far as surveillance for the pulmonary manifestations of tuberous sclerosis, the main thing we're concerned about is the LAM. And in addition to getting a baseline CT late adolescence, particularly for women, but also for men, we like to now get imaging of the anatomy by chest CT every 5 years, regardless of symptoms. In addition to that, if a person is able to cooperate, pulmonary function tests at least every couple of years are also big help in tracking progression of disease. So for the skin findings, most of the findings that are associated with tuberous sclerosis are not symptomatic and don't cause problems. I think some of the facial angiofibromas